Good afternoon, dear students. Do you hear me clearly?
Good afternoon, teacher. Yes, teacher.
Good afternoon.
Oh, great, great. Happy to meet you. I didn't see you at the moment. Please switch on your cameras as well. Are you here? Dear students, are you here? Do you hear me? Maybe anything
Yes,
is
teacher.
wrong? Oh, yeah. Let us get acquainted with each other. Just let me check if all the students are present. Maybe you can help. How many students are there in your group? How many people do we expect today? 1, 2, 3, 4, 5, 6, 7, 8. 8 students, right? Are expected. Am I right? So please, dear students, switch on your cameras and let me start the class for you. Are you okay? Hello. Thank you. Are you in safe place? Nice. Thank you. Thank you for switching. Waiting for the Hyla, right? Happy. Are you here? Okay, anyway, glad to see you and in general to meet you. Let me introduce myself. As it is stated below, my name is Alexey Kalmykov. The first name is Alexey, the family name is Kalmykov. I'm professor of the Department of Internal and Occupational Diseases of Kharkiv National Medical University. And today we're going to have a practical class in internal medicine with you. And I expect that you are students of third year, specialized in dentistry, right?
Yes.
Great, super. By the certificates, my specialty is therapy, so it's equal to internal medicine. I'm a therapist, and I'm eager to help you to master this branch, this field of medicine. Why did you switch off your cameras? Could you let me know? Dear students, I'm just wondering, you see, you may just comment if you need to switch the cameras. It might be okay. Just inform me the reason. Is there any danger for you to keep the switch on? Yes or not? Okay. Tell me, please, have you already have the lecture in internal medicine yet? Did you have the lecture in today's topics or anything?
Haven't yet.
Could you repeat, please? I'll adjust my earphones.
Not yet.
Not yet. Oh, so it's the very first now, right? The very first particular class for you. And lecture, you didn't have any lectures before, right?
Yes.
So such a big responsibility for me. Okay, do you have, well, you definitely have, but just a moment, I'm sorry, just a few seconds. So sorry for this pause. Uh, how do you feel? What's the reason for you to have such a subject? You are going to become dentists, right? So what ideas do you have about internal diseases of internal organs? Maybe you have heard about anything, or you have some ideas, thoughts about how do they correspond to your future practice, your stomatological dental care? Is there any link between the condition of internal organs and stomatological or dental pathology? Maybe you have heard about this from the course of stomatology or dentistry, maybe from pathologic physiology, pathologic anatomy, or just your everyday experience. Do you have any ideas in this relation? In general, what internal organs do you remember? And let me explain this matter for you. What do you understand by internal organs? If you are talking, your microphone might be switched off, so turn it on.
Maybe lung,
Yeah.
liver, kidney.
Great. Yeah, sure. For instance, the first organ you mentioned is our today's special point of interest or sphere of interest. Today we have the topic of bronchitis and chronic obstructive pulmonary disease and pneumonia. Let me check. For instance, did you see the links in your invitation for today's class? I have supplied the major, at least, links you might need in this relation. Do you see them inside the invitation? There is a plenty of links there. Let me show you on the screen, just one moment. Here it is. Do you see my screen now? Yes? Do you see my screen?
Yes.
Oh, great. There inside the invitation for today's class in the Google calendar, there is a link to our today's meeting in Teams, and then the link to lesson 1 in Moodle platform. Have you enrolled already to this course? Who has?
No.
Okay, please take care about this. First, open the invitation. There inside the description, there is a direct link. In order to make it more convenient for you, I will copy paste it now. One moment. To our chat with you. If you experience any problems with direct. But in future, take care about these contents, okay? Because in every of our classes or lectures, I supply some links, some materials inside the invitation. So if we choose the second class with you, there are also some certain links to your materials that might be useful for you, okay? So check the link in the chat I have supplied for you and enroll to the course of internal medicine here. Let me do it for you now, illustrate how to do it. Okay, if you follow, you will be invited here. I am already enrolled, but you should just press the button and get inside. Who has already enrolled to this course by the link I supplied for you in the chat?
I did it, sir.
You did, right?
Yes.
Great, great. Who else? Dear students, Hanchit Hui, do you have any problems with this or what? How can I help?
No.
Have you enrolled already? Have you joined this course in the Moodle as I show on the screen?
Yes, I joined.
Already?
Yes.
Great. Juvental, did you?
Yes.
Khaled Balen?
But I can see your screen. It's blackboard.
Oh, maybe I just one moment. Let me repeat it. But the question is same, regardless whether you see my screen or not. Have you joined, enrolled to the course already or not?
Yes, already.
Great,
No.
thank you. Khaled, you told something? Khaled Balem. Could you repeat and speak more distinctly, please? Maybe you'd better write because I didn't recognize what you said. Ismail El Hajami,
Yes, teacher. Yes.
have you joined the course already?
Yes.
Great. Otman Belkhadri. Otman Belkhadri, I don't hear you if you're talking. No sound. Write, please, if you're... No, I don't hear you. No, I think no one hears you. Maybe you should let the teams get access to your microphone.
Teacher,
Yeah.
you can hear me now.
Yeah, now it's clear. Yeah, now it's much better.
I can't open.
Okay.
Maybe you can send again.
Your speech is not clear, but in general, I heard that you have joined, yeah? You have enrolled to this course, right? Already. Otman Belkhadri wrote that's already joined. Okay, I'm not sure, but maybe we have discussed with every one of you, right? That you have joined. Good. The second one I'm trying to show you on the screen. Let me see if my screen is visible for you. Do you see my screen now?
Yes.
Oh, great. Super. The next, as I introduced in this invitation, there is a link to what? To the first lesson, right? And the Davidson's Essentials of Medicine. This textbook is advised for you in terms of mastering, okay, this subject as a basic textbook. Maybe I would manage and develop and publish for you our own textbook, or maybe not, if not textbook, but at least some kind of manual or guidelines or something like that, additionally to this one. But as for now, please use it as a main, okay? For your preparation. Good? Have you found it in the Moodle?
Yes.
Here on the left, there are main aspects of the course. Presentation, program, syllabus, glossary, etc. Feel free to look through all these, maybe in your time, not even importantly, so urgently now. But in general, I'd like you to introduce these things, some main things for you now. Then some extra information I will do my best to place on my personal website here with some links to different locations. I will update it because I wrote this message about half a year ago, and I'm eager to upgrade it and update while cooperating with you. Good. And here are my contacts if you need any explanations, if you want to conduct some kind of students' research work. Feel free to contact me by email. I'm stated here as the creator of this event, of this practical class. Here is my corporate email. This is maybe the most convenient way for you to get contact with me. Good. So let me think how to do it better. Probably it's good if we learn to these things. Maybe with my help, but I have some idea how to organize your work, your independent work. Take into account that you didn't have the lecture yet. I didn't expect this because I thought you have already been prepared. I have sent invitation for today's class with all the topics. For instance, today's topics, as you can see on the screen and in your invitations, are chronic obstructive pulmonary disease with pulmonary emphysema, pulmonary insufficiency, these main aspects. And here are the main materials regarding these topics. You may see there are bronchial asthma and chronic obstructive pulmonary disease for today's class. And here are the main links for your independent work as a sources. You may attend this COPD resource center and look through the material, and smoking cessation resource center as well. You may see, just open it and look through. Let me close the not needed tabs. And Cochrane library. Do you know such a it is Cochrane collaboration, one of the most fundamental and up-to-date and evident, or maybe source of evident information, medical information. If you follow this link, you will get to one of articles placed here, but you may use the others as well. And my advice to you is to base your decisions as much as possible on the material presented in Cochrane collaboration or Cochrane library. Cochrane collaboration is the wider organization, and it has a library inside it as the subsidiary project. Good. Tell me, please, what questions, maybe organizational questions, maybe any other, do you have at the moment, and I can help you with them? What questions do you have now? in anything regarding the subject, topics, maybe our studies with you or anything? Dear students?
For me, I don't have any questions. Everything is clear, sir. Thank you.
Thank you for your response. I just, this is general question, not personally to you, but to all the students. Tell me, please, why are you switching off your cameras? Why? I just want to know, because it's unusual for me when so many students are present and no one is has camera on. What's the
I don't
reason?
know, sir, but like all the classes we have are like this. We switch off the camera and the microphone.
Mhm.
But if
No,
you want, we can open it. It's fine.
No, I understand why microphones should be muted, not to produce so much noise. But as for cameras, it's our chance to see each other, to have visual contact. So, for me as your teacher, to help you master some material better with this feedback from you.
Okay.
It depends, of course, but I believe that you'll get better results if you would be on camera on. Let me
Yeah,
find.
okay.
It's for you. I just wonder why it's so. It's okay. Let me find some things. Just few seconds or minutes. Oh, great. Glad to see you. Hello. Thank you for turning on. Just one moment. I'm looking forward to find some maybe a material, theoretical material to explain you, because you haven't prepared, right? Or you have? Have you prepared for today's
No,
topics?
we
No,
haven't
no.
prepared. I think we didn't even have the lecture.
Yeah, I was told that you didn't have. That's a pity. That's why I'm trying to help you with this. Let me see if I can. Okay. I'll show you something now just to introduce the topics. Anyway, you are going to have your lecture later. Just one moment. Let me show. Just a few. Okay, so I share the screen now with the presentation. 5. And here we are. And where is it? Let us take this one. Do you see my presentation now?
Yes.
Oh, yeah. So I will try within next some up to 1 hour, maybe. I hope. I hope to introduce main topics, main diseases we are going to discuss with you today, and to just one moment. I'll change the screen, and to help you understand them better. And please, what I expect from you is to be attentive, actively thinking, and having some questions. Yeah. So the best response, the best feedback from you to me would be, in my, of course, understanding, would be your questions. You see, your interest, your some value that I would give you by our today's class. This is my main reason. This presentation has been prepared by my colleague, Dr. Mazur, and thanks to him, I have the chance to discuss this with you. So, first, the thesis. Chronic obstructive pulmonary disease and bronchial asthma, which you probably heard about already previously, form the majority of respiratory diseases we are faced with. In the almost as it is stated on the screen, up to 10%, just imagine, of all adult people have more or less expressed bronchial obstruction, and sometimes even with already diagnosed disease. Again, COPD abbreviation means chronic obstructive pulmonary disease. Chronic means with prolonged course, right? Obstructive with disturbance of patency of bronchial tree, and pulmonary related to lungs disease, it's pathology, right? And unfortunately, this disease, most strictly COPD and together with bronchial asthma, causes high level comorbidity. By comorbidity, we understand that it's combining of this respiratory pathology with some other connected with it. For example, combination of COPD and coronary artery disease. Maybe you heard about myocardial infarction or stenocardia or angina pectoris, or combination of COPD and how it is named, GERD. It's gastroesophageal reflux disease, right? And in turn, gastroesophageal reflux disease is connected with dental pathology, with changes, inflammatory diseases of oral mucosa and other changes. And mortality is high, as it is stated on the slide. It exceeds 10%. It's very much. Here are some statistical data about connection different diseases with mortality, ischemic heart disease and cerebrovascular, etc. As you can see, COPD is almost on the same level as human immunodeficiency viral pathology with how it is named, acquired immunodeficiency, right? And the main initiative, the main maybe community of medical doctors specially intended to research, to develop diagnostic treatment, prophylactic rehabilitation measures is represented here on the slide, Global Initiative for Chronic Obstructive Lung Disease. The acronym is GOLD, or GOLD, yeah, GOLD, like such a valuable element, chemical element. Later, or not even later, but in your materials on the Moodle course, you have links to this GOLD website, and the most modern information is placed there if you would ever wonder about. According to this GOLD initiative, starting from 2006, it's a disease characterized by obstruction, so disturbance of patency, right, of mostly peripheral, small-sized and middle-sized bronchi, and with further accompanying changes of the lung parenchyma. On this definition is stated emphysema, right? It happens when lung parenchyma becomes remodeled, enlarged, and damaged during this remodeling, and we call it emphysema, right? In this case, a lung emphysema, because there could be different locations of it. The main pathogenical aspects of COPD are associated with, from one hand, hyperactivity of how it is named, autonomic nervous system, parasympathetic nervous system. For other hand, changes in receptors inside the bronchial walls. And finally, this results in bronchial hyperreactivity. In general, a part of these two changes, namely narrowing of bronchioles and development of emphysema, etc., we have 5 main components of bronchial obstruction. These components include hypersecretion, then bronchial spasm, bronchospasm, hyperproduction of mucus, increased viscosity of mucus, and fifth is deformation of bronchi. Again, bronchoconstriction, or bronchospasm, narrowing of the bronchial walls, plenty of mucus, and increased viscosity of mucus, and fifth is deformation of bronchi. I'll change the slide. I see that you might copy something, but I gave already access, or I can give you access now. Just one moment. Let me do it for you just exactly now. I'll give you now access to all my presentations I'm showing you, okay? So it will be more efficient for you. Let me copy paste it to our chat. Just one moment. Again. Let me sign presentations. Check please if this is accessible. I copy pasted the link to all these presentations in all of today's topics into the chat, Teams chat. Do you see it? Yeah.
Yes, teacher.
Yeah. Okay, so I just didn't want to interrupt you, but I want to supply you with these materials so you will get them as like conspects, right? And we'll focus now on discussion. So if you would get any questions, let me know, raise your hand or just start talking. I'll do my best to explain anything to you. So again, there are even some more stated here pathophysiological aspects. Hypersecretion, dysfunction of ciliary epithelium, I didn't mention it. If you remember, inside the bronchi, the peculiarity of an epithelial layer is the presence of cilia. And the main mechanism and main function of this ciliary epithelium is to get the mucus with dust particles or anything what is placed there, get excreted from the organism in general and bronchial tree as well. But this function of this ciliary clearance leads to accumulation of mucus, leads to development of subacute or acute and then chronic inflammation inside the maybe on the mucous membrane, then inside it and under it, and this inflammation starts to occupy the surrounding tissues, etc. So it's important also. Decreasing of airflow in bronchi is mediated by decrease of patency of the bronchial tree by itself. Hyperpneumatization of lungs, I have already commented, because of this disturbance of permeability, right, of the bronchial tree, a mechanism of pump, a mechanism of valve appears with accumulation of air inside the lungs, increase of its pressure inside the lungs, and enlargement of lungs, development of this emphysema. We name this mechanism of hyper increased pneumatization. There are too much air inside the lungs, in other words. Disturbances of gases exchange. Again, the gas exchange takes place from between the bloodstream through the vascular wall, then some interstitium, and then alveolar wall, walls of alveoli. And in terms of this lung pathology or respiratory pathology, the continuous prolonged inflammation, even in bronchi, systemically leads to some kind of thickening of the interstitial layer, in this membrane, right, on this foci, and this decreases the permeability of this layer, you see, for one hand. For other, rather often in people with a prolonged course of COPD, chronic obstructive pulmonary disease, more or less expressed inflammation takes place in alveoli as well. It may lead to development of alveolitis or pneumonitis, so focal, yeah, or distributed inflammation of lung parenchyma, or not so much, but anyway, gas exchange is suffering in this condition. And in rare cases, there also could be affection of endothelium, the inner layer of vessels, with thickening, with dysfunction, etc. And this also leads to disturbance of gas exchange. So again, it seems to be, by the definition, by the name of this disease, that there is some problem with bronchi only, but not so much. It also, this inflammation and different changes are distributed all over the organism. And just imagine if there is problem with oxygenation of blood, it's a hypoxemia of all the tissues. Hypoxemia is the lack of oxygen in blood, and the hypoxia of tissues leads to disturbance of their energetic metabolism and disturbance of all the systems and organs, including oral sphere, including dentistry, right? Then the 6 points in this list: pulmonary hypertension. Due to this continuous, prolonged inflammation in bronchi and deformation of them, the vessels surrounding the bronchi and supplying blood to the lungs, to the bronchi, etc., they also undergo some deformation, some disturbance. It's for one hand. For other, there are also problems with endothelium, as we already mentioned with you, endothelium dysfunction, and this leads to finally increase of resistance of vascular tree inside the lungs, and increase of blood pressure in small circulation. And we name this pulmonary hypertension. So we distinguish small circulation and major one, right? And increase of blood pressure in small circulation, it mostly happens inside the lungs, right? So that's why we name it pulmonary hypertension. This pulmonary hypertension may be connected with the systemic hypertension or not so much. It depends on whether it is compensated or not so much, yeah, or not or decompensated. Finally, when some person suffers from COPD for prolonged time, with deformation of bronchi, with increase of blood pressure inside the small circulation, right? And with increased resistance and pulmonary hypertension, this leads to increased load on right parts of heart, right ventricle and right atrium, right? Compensatory right ventricle and right atrium undergo some hypertrophy. Yeah, it's compensatory primarily. And this condition with hypertrophy and sometimes even dilation, enlargement, yeah, of the cavity of right ventricle and right atrium, we call this condition as cor pulmonale. Cor pulmonale. It's remodeling of heart, and this may in turn result into decompensation in development of heart failure by right ventricle type and pulmonary edema, etc. Not stated on this slide, but in general. In this condition of disturbance of oxygenation, disturbance of blood supply, and systemic affection of all the organs, of course, more or less, but oral sphere also suffers. Yeah, and these people, these persons, patients with COPD, especially in prolonged course, they develop dystrophic changes, inflammatory changes of stomatological kinds as well. Here is the illustration about what happens inside the bronchi. Hyperproduction of mucus, of increased viscosity, thickening of the bronchial wall, and it is not stated here, but you may imagine that these bronchi become deformed and hyperreactive. Even ordinary, usual, common factors may result in bronchospasm in such people sometimes. It could be even smoke from someone else, not even if this person doesn't smoke. Or it could be inspiring of some cold air. Or it could be just stress, mental stress. This may already result in bronchospasm in these persons with appropriate reaction. Here are some illustrations, classic, I must say, illustrations of what happens inside. Again, in chronic bronchitis, there is a thickening, this edematous condition of mucous membrane of bronchial tree, increased quantity of mucus in turn. This results in accumulation of air and formation of emphysema. And finally, it results in chronic obstructive pulmonary disease. In comparison to this, on the right side of this illustration, there are pictures of average normal condition of bronchi and alveoli, okay, and bronchiole. Here is the scheme, what happens while developing of emphysema. Some alveolar walls undergo deformation and even sometimes disappearing, enlargement, etc., and this results in this remodeling of lungs. There are different concepts or theories of what exactly happens inside the lungs, and a set of markers are developed to detect these changes. But this is maybe information useful for research, for some sophisticated approach to this matter. I will not focus on this with you now. While I'd like to maybe, here is might be useful for you. Just one moment, let me enlarge it. You may see the some kind of specimens, right? Histological specimens. What happens inside the tissues, such inflammatory changes inside, right? In different severity of chronic obstructive pulmonary disease. Here is one of the possible mechanisms with influence of some pollutants from outside and even irritants, with reaction of fibroblasts and production of collagen, and direct reaction of inflammatory cells, neutrophils, macrophages, and then production of collagen and elastin and other proteins, resulting in fibrosis, right? Fibrosis of the parenchyma and bronchial tree of lungs. Typical history, which almost every patient with COPD represents, concerns smoking, maybe some occupational hazards, like there could be different kinds of dusts present on the place of work of this person. Rather often we observe COPD in workers like electro welders or workers of foundry departments, or miners, from mining industry, or even road workers, or in construction, or in production of building materials, etc. in those places, in those occupations which are connected with the influence of air pollutants, inspiration of them, accumulation and development of inflammation, etc. And of course, some significance is related to hereditary factors, and you may reveal this by, or maybe from, family history of the patient. If his or her parents and grandpa and grandma and maybe brothers and sisters, siblings, right, etc., are suffering from respiratory pathology, especially chronic one, especially obstructive, the probability and the risk of development of similar changes in this person is increased. And there are even certain genetic markers related to these aspects. For example, disturbance of the genes in genes coding alpha-1 antitrypsin. Then there are peculiarities of genetic oligonucleotide polymorphism of surfactant proteins type C, type D, and many others. There are dozens of them. Complaints. The main complaints these patients represent concerning so-called bronchitic syndrome. We name it bronchitic syndrome, and bronchitic syndrome in turn has the main symptom of cough. What do we understand by chronic cough, as it is stated on this slide? We name the cough chronic, and therefore there is a reason to diagnose at least chronic bronchitis or even chronic obstructive pulmonary disease when the episodes of cough last for at least 2 months or 3 months, at least 2 times a year. Oh, pardon, one moment. They last for 1 month, at least 2 times a year, 3 times a year during 2 years. So the minimum duration of repetitive prolonged cough enough to diagnose the COPD or chronic bronchitis is 2 years. If it lasts less than 2 years in general, we do not say it's chronic, right? And also it's important to evaluate the duration of each episode. It should exceeding 3 months, right? Sputum. This cough might be productive or not productive. So sputum is not always present. Non-productive cough is not accompanied by expectoration of sputum, or if any, it is very viscous, right? Like a colloid, yeah, colloid condition. And rather often people represent so-called irritative cough without expectoration of any sputum at all. This is typical for those cases when inflammation of bronchi is caused by irritative influence, by some toxic substances or irritative substance. For example, it could be in smokers, for instance, yeah, inside the typical smoke, yeah, smog, yeah, smoke. There are components with irritative influence, and a part of absorbing of nicotine and other substances. This smoke also causes and leads to development of local irritative changes, and this might be accompanied by irritative cough without sputum at all, or they could be vice versa. So prolonged course of this chronic bronchitis or COPD that the glands inside the bronchi producing mucus die, or they simply replaced with the fibrosis, and a lack of mucus is produced. It's also bad. So much of mucus is bad, and lack of it is also bad, because this is one of mechanisms of elimination of dust particles and etc., irritative factors from the mucous membrane. While if mucus is not enough, it's a problem. So non-productive cough might be also an important diagnostic criteria for both chronic bronchitis and chronic obstructive pulmonary disease. What's the difference? The third symptom presented on the slide, dyspnea or breathlessness. In chronic bronchitis, dyspnea does not develop. It's not typical, at least for chronic bronchitis, but dyspnea is highly typical for COPD. It depends on conditions in which it develops. So in subcompensated or fully compensated COPD patients, dyspnea might be absent at usual condition, right? It may develop even in healthy person only at hard physical load or something like that. While the obstructive component might be already present. So again, person might represent cough with expectoration sputum or without, maybe no dyspnea, but nerving of these of the bronchi and obstruction might be already present, not recognizable physically, at least not presented in complaints. I'll show you slightly later how to diagnose such cases. Physical signs, by physical signs, we understand what a medical doctor may get from physical examination of the person, right? Extra, additionally to complaints, to getting anamnesis or history of the patient, etc. Central cyanosis, cyanotic tinge of mucous membrane of lips and sometimes fingers, edges, right, and of upper and lower extremities as well. And in some extremely complicated cases, severe cases, there could be even systemic cyanosis. It's typical in case of so-called respiratory insufficiency. If respiratory insufficiency is absent, there will be no cyanosis. The mechanism of cyanosis in this case is what we have discussed with you in pathogenesis, lack of oxygen in blood. It's hypoxemia. Yeah, hypoxemia. In this condition, the color of hemoglobin, or better to say, different components of fractions of hemoglobin, oxyhemoglobin, carb hemoglobin, turns into more parts of carb hemoglobin. It's combination of carbon dioxide and hemoglobin, and this substance has more dark tinge of the color. That's why on the mucous membrane and on the skin we observe this as a cyanosis. By cyanosis, it's like bluish or sometimes with some grayish tinge discoloration. We should also be able to distinguish the cyanosis is caused by a lack of oxygenation due to respiratory pathology or problems with blood supply through the vessels due to heart or cardiovascular problems. In case of COPD, this cyanosis is caused by disturbance of oxygenation, but with normal bloodstream, if there are not complicated cases, of course, not comorbid. And if you touch the lips, touch the fingers, etc., regardless of whether they are cyanotic, they remain to be warm enough, because of good blood supply. While if the cyanosis would be caused by heart problems or cardiovascular problems, blood and vessels, it will also same cyanotic but cold, not cold actually, but cooling, not normally warm. Okay, that's why we distinguish cyanosis related to respiratory pathology and to cardiovascular. But of course, in severe cases of COPD, it could be a combination of cardiovascular and respiratory pathology. In this case, the cyanosis will be stronger and it will be cold, as it is in case of disturbance of circulation. Then emphysematous chest. What do you understand by this? It's enlargement of chest, right? You may see this deformation that person has like hyperinflated position of his chest. Then involving of additional breathing muscles, as it is stated on this slide. Due to the fact that there is problem for this person, for this patient to conduct expiration than inspiration, he tries to involve additional muscles, and sometimes even they take a forced position with positioning them hands on some wall or maybe some table, etc., and involving additional muscles of the upper extremities in this breathing. You see, it's so hard breathing. And if you listen to peculiarities of this breathing, you will observe a part of this increase of breathing rate, also more prolonged expiration phase. Sometimes you may hear rails, distant rails, even without stethoscope, on expiration phase. And this is highly typical for obstructive conditions, for COPD and attack of bronchial asthma, right? If you of course are experienced it, I'm not sure that you as dentist would perform this, but if you perform percussion, a bang box sound appears. And there could be also some dullness in interscapular region because of enlargement of lung roots, because of peribronchial fibrosis, etc. If you continue with physical examination with auscultation, as we have already mentioned, that sometimes you hear distant rails, yeah, and even whistling as dry rails. And if you continue with auscultation of heart, the dullness of heart is mediated by the enlargement of lungs due to lung emphysema and covering of lung edges the heart region, you see, and thickening the layer of lungs between your stethoscope and heart. But probably you as dentist will not conduct this auscultation, typical classic auscultation, but at least listen to distant rails. It might be useful. The main investigation or additional investigation methods needed to diagnose COPD, according to GOLD initiative, include spirometry, or we also name it spirography. By spirography, it's same as metros, measuring, right, and graphos, writing something. It's measuring with writing a curve. By the methodics of this spirometry concerns two aspects, two main phases. We measure volumes. This person may inspire and expire and summarize all this in a vital capacity. And separately, we measure the ability of this person, of his lungs and bronchial tree, to expire quickly as much as possible. So we ask him to inspire deeply through the mouth and then expire as quickly as he can, measuring forced expiratory flow, yeah, forced expiration and forced vital capacity. And typically, the ability of this person to expire deeply with force is significantly less than ordinary breathing. This is one of the main important things you might remember, because again, you are not probably be pulmonologist or specialist in spirometry, etc. But in general, in persons with COPD, with obstructive changes, there is problem with expiration phase. it becomes more prolonged, it becomes obturated, more difficult, etc. And we may observe this on spirometry, on this maneuver with forced expiration. Second one, stated in this slide, is bronchodilation test or bronchodilation test. It is same spirometric test, but we additionally ask the patient. So we measure basic volumes and speeds, right? Velocities, and then we ask patient to inhale bronchodilator. And then repeat this spirometry in 15 minutes, for example. There are different methodics, but in general, we wait until the inspired medication acts, and then repeat the spirometry. And if the restoration of permeability, of the ability of bronchial tree to expire is restored enough, it's not COPD. But if not, if it remains, it is COPD probably. So again, this second mentioned bronchodilation test is aiming on revealing if this obstruction is recoverable or not so much. It's important for us in terms of both diagnosis and treatment and rehabilitation and everything. Then the third point stated on the slide, cytology of sputum. Unfortunately, many of etiological factors which may lead to COPD may have other consequences like cancerogenesis, like allergization and sensibilization, etc. And taking the sputum and the cytological analysis of sputum help us to reveal, is this ordinary inflammation or there are some allergic components in this sputum, right? Or there are some malignization or a tumorous growth. Is this clear? And even more, it's important for us to reveal possible growth of special infection or maybe even parasites or some other things from sputum. By this, we suppose what exactly happens there inside. Good idea is to get not just sputum, but we name it bronchoalveolar lavage fluid. Bronchoalveolar lavage fluid. We take this fluid directly from the bronchi by bronchoscope, such endoscoping equipment. So we inject some quantity of just physiological solution there inside, and then conduct the suction back of it and analyze the cytology of it and so everything present inside. It's important of us because whether some sputum will be expectorated or not, now or other time, it's sometimes very difficult to collect the sputum from these patients, and getting this bronchoalveolar lavage fluid is the only way to take anything we need from the bronchial contents. The fourth one present on the screen, blood analysis or complete blood count and biochemical blood test, etc. Complete blood count represents typically signs of inflammation with growth of I forgot English term for this. One moment. Nitrophiles. How is named? One moment. I'll translate it in the vocabulary. I forgot the term, English term. One moment. Палочка ядерный палочку ядерный нитрофил. It's палочку ядерный. Oh my God. It's incorrect translation. One moment, let me find correct one. There are two types of neutrophils, segmented and how it is named? Could you remind me, please? Segmented and before them. Do you remember? Oh my God. How could I forget it? Just a moment. Let me find. Oh no. Oh no. What's wrong? I can't find. It is translated by Google Translate as rod shade, but no, there are other translation. Rod shade neutrophils. Maybe let it be. So again, there is a neutrophilia in general, typically, right? But in case if COPD is caused by some sensibilization agent, yes, and sensibilizing agent, allergic agent, there could be also increase of quantity of eosinophiles, etc. And in case if it is connected with some maybe specific immunity involvement, there could be also increase of lymphocytes. Yeah, good. Then there is increase of erythrocyte sedimentation rate, incomplete blood count, and these are main changes. Sometimes we may observe also increase of hemoglobin concentration and quantity of red blood cells is due to compensatory attempt of the organism. Then, from side of biochemical blood tests, you might reveal non-specific increase of concentration of so-called acute phase parameters, right? C-reactive protein, seromucoid, and etc. Next, X-ray. X-ray is essential for us not even to reveal the COPD by itself, but to reveal its complications or to perform the differential diagnosis between COPD and other conditions. For example, tuberculosis, cancer of lungs, pneumonia, pneumonitis, alveolitis, pneumoconiosis, what else they could be, etc. Right? X-ray help us greatly. It could be ordinary X-ray, indirect projection, yeah, sagittal of the chest, or it could be computed tomography X-ray. Or even in some rare cases, we also use not X-ray, but electro, how is named? One moment. Magnetic resonance imaging, yeah, magnetic resonance imaging, MRI. Then electro cardiography, yeah, electrocardiography, ECG. We use it again to evaluate the condition, functional condition of heart in patients with COPD. Typically, there are direct or indirect signs of hypertrophy of right ventricle, for example, or they could be arrhythmias and other conditions. And blood gases evaluation is useful in case of signs, clinical signs, or physical, signs of respiratory insufficiency. And blood gases evaluation help us to be sure about how intensive, how severe this respiratory insufficiency is, and apply appropriate treatment, maybe with oxygenation, maybe with some other things. Okay, if you get any questions, feel free to ask. On this slide, some certain parameters are stated, as I already mentioned for you. Forced vital capacity, FVC, yeah, or forced expirative volume of on first second. It's one other parameter, and its relation FEV1 to FVC, and peak flow changes, and maximal expiration velocity as well, and many other parameters might be measured, but these are main in spirometry. Maybe you as a dentist will not be faced with the need to evaluate these parameters, but I'd like you to have at least general ideas about it. Same for X-ray, on X-ray. in COPD. There are enlargement of lungs, hyperinflation. There could be depression of diaphragm. There could be the narrowing of heart shadow due to hypertrophy of it, right? And of course, there could be increased foci or regions of increased X-ray transparency due to emphysema of lungs. Here is the outlook, what exactly happens. Increased transparency, condensed condition of lung roots, right? Here they, and enlargement of hearts, especially of right border of heart. One more example. In this case, it becomes even more, as you can see, the intensity of lung pattern is increasing, right? The enlargement of hearts, especially right border, is more expressed. The bronchodilation test is performed with typically with salbutamol, 400 micrograms of it, and then we repeat the bronchodilation test. Here is the classification of COPD based on clinical phenomena and mainly spirometric data. We distinguish 4 grades from first to fourth, right? And there is also a pre-disease, pre-COPD. The principles of treatment correspond to, first of all, probably improving of the life conditions of the person, stoppage of or cessation of smoking, reasonable employment if needed, if his place of work is related to influence, to inhalation of some causative agents, right? Then it's a group of measures aiming on getting the right patency of bronchial tree, of bronchi as well. It may be in terms of physical exertion, it may be optimal relative humidity of air in the place where this person lives. It could be use of bronchodilators, anti-inflammatory drugs, and it depends, and also treatment of some accompanying diseases and consequences, I mean complications, etc. Here is the peak flow meter. Peak flow meter. It's a very compact, small gadget by which this person may measure peak, literally peak. So it's maximal, right? Maximal velocity, maximal speed with which he may conduct the expiration. In this case, here is the nebulizer or inhaler, ultrasound, compressor inhaler, with which it's the best way to get the medications access the mucous membrane of bronchi and get absorbed and act locally, not systemically as we previously used by injections or by peroral use, but locally influence on the condition of bronchial muscles, enlargement of them, and even decreasing the intensity of inflammation as well. Here is the example of personal small inhaler supplied with tiotropium bromidum. Tiotropium bromidum. It is so the patient may buy once, and then this equipment and this gadget, and then just buy the nebules by which he may inspire. It's in form of powder, not even the liquid, but powder inside. And the main medications, so groups of medications are from the group of cholinelytics, of short action, of prolonged action. We already mentioned with you tiotropium bromidum, and I also mentioned ipratropium bromidum. Yeah. So there are appropriate results of investigations of researchers in this relation. Then, a part of these cholinelytics, we might also use broncholytics directly with beta-2 agonists of short or prolonged action. Salbutamol or salmeterol or formoterol. It's the other group of medications might be used here. Methylxanthines, right? Theophylline. We try not to use them, to avoid using. If the previous groups act, we use only them, starting from cholinelytics up to broncholytics, and then only if we do not succeed using methylxanthines. Even if we do not use them, maybe the next choice is to use glucocorticosteroids as anti-inflammatory drugs. They decrease the thickening of bronchial wall. They help to decrease the reactivity of bronchial muscles under the influence of pollutants, etc. Of course, we use inhaled forms as much as possible. Only when inhalation is impossible because of respiratory insufficiency or this way is not effective enough, we use systemic injections, yeah, of them. Here is the evidence of use of them. Depending on the severity of disease, there are different protocols of treatment developed. You may read about this by yourself. I will not detailize it now. Here is the even staged, it is named staged therapy, right? Depending on stage of the severity and effects of the medications. If we succeed, we stop on this. If not, we add something, right? And of course, main is cessation of smoking and influence of other pollutants. Okay, so it's time to make a break. Long ago, I forgot about break. How would you prefer to conduct these breaks? For how long, or without breaks, or how would you prefer?
I think without breaks.
Okay, what questions have you got regarding COPD, or maybe any other questions, organizational or other? How can I help you?
To be honest, there is a lot of new informations,
Of course.
and we need to read this lecture many times so we can understand everything and remember all the most important informations.
Of course, I understand this. I'm just trying to help you. See, unfortunately, you haven't been prepared before. That's why I just choose how to do it better.
Yeah, thank you.
What can we do? We can continue with other theoretical material, or I can give you it for some task for independent work. How would you prefer? Because I see that you are tired more and more. Yeah.
I prefer to give us some task to do, and we will have time to understand it.
Okay. You told that all of you have joined, have enrolled to this course already, right? And there is a plenty of materials inside it. And let me show you on the screen, just one moment. Let me share it. Okay, so we'll do it now as you propose. Do you see my screen now? Yeah?
Yes.
Yes. Look here, at the end of each lesson, here is the first lesson, right? We have a part of independent student work. I have commented it. We have also, let me see, Lesson 1, topic 2. Oh, independent test. Here it is. Task for lesson 1. You see, after you have studied everything, after you have no special questions, I'd like you to pass these tests, okay? Good?
Yes, teacher.
Okay. In order to help you with arranging the information in your independent work, I would prepare and send you, I'll show you now, but I will prepare separate document for you, such a template, you see. This one is in occupational disease. You don't have such subject at all, but I will prepare similar, but in internal medicine for you, where you will have some contents here, right? Then a place where you may put your questions to me or for your discussion. Just don't hesitate to write here anything, you see? And you may even mention me. Look here, just one moment. If you do like this and choose me, or Kalmykov, KNMU, EDUA, right? You may highlight that it concerns me. Or if you add, for example, add command and mention me here, right? I can mention myself. I will get information to my email that some student requires my attention. Look here, I'll show you now. Just one moment. It will take a few seconds to, it's lagging some way. So if I sorry, it's other account at all. One moment. This one is corporate. It should appear. No, it's not. Maybe it's not present because I command it. You see, if I command, maybe they will know. But as you can see, when some student mentioned me, I have information that he has or she has added something, and it requires my attention. You see, so when you get this access to the file, I will prepare for you separately. Don't hesitate to mention me if you need my help. Yeah, just in commands or inside the document, and I'll help you. Next, it's what's this? I'll put appropriate topics here, not in occupational disease, but in internal medicine, as we have with you. But what is important, I'll represent the blank table for you, where you may fill in information about each of diseases. For example, chronic bronchitis. Let me show you. Even we have chronic bronchitis, but different, not same as yours. We have chronic bronchitis of dust etiology, yeah, or COPD of dust etiology with other students from medical faculty. But in your case, you will put here chronic bronchitis, ordinary, right, or COPD or bronchial asthma, whatever you want, and arrange the information in terms of what? Complaints and history, common for all these diseases and specific for each disease. Then physical examination, again, common for all these diseases and specific for each of them. And additional investigations, laboratory instrumental, common for all of them and specific, yeah, for each of the diseases. Is the idea of this table clear for you?
Yes, sir. It's like a resume.
Yeah, it's useful for you because I believe you will never be pulmonologist or therapist or general practitioner, etc. While you become stomatologist or dentist, you will have a conspect. You will have general idea how to manage some patient in terms of just complaints and history. You will not be obliged to perform all the rest. Or if you, for example, by some reasons, maybe this is your some how we name it, some friends or maybe relative even, maybe you'll be involved more with physical examination, maybe even with the rest of aspects, right? It depends, but you will have so-called layered arrangement of all needed for you, okay?
Okay.
Okay, then I will put the chapter tests and direct link to the test we have already discussed with you, right? Present here in the Moodle. And sources, I will advise you some sources, but most of them are already present in the Moodle, and you may add by yourself. If you find some good material, please fill them, make a reference here. And I'm not sure, I can't promise that I will be in time, but later when I'll get this information, I will collect some theoretical materials for you. Because frankly, I am eager to develop, as I introduced at the beginning of today's class, I'm eager to prepare some manuals, methodic recommendations, guidelines, and even up to textbook or even up to a big course in internal medicine until we finish with you this course together with you, if you don't mind. And you will be co-authors of it if you want, of course. If not, I will at least put their acknowledgements, right? Thanks to the following students, this material was developed. Okay?
Okay.
Okay. Good. So you may have a rest probably now because you might be tired. I will, during some short time, in some minutes, prepare this document for you and send by email. You'll get it, the access to it. Okay?
Okay, so we may be free now, or it's just a little break.
I propose you to have a break as much as you want, then work independently, and I will stay online till the end of official time.
Okay.
If you need my assistance, you see, you may choose your regimen, whether to work now or have a break or do other things. It depends on you. But I will be accessible during all this time online. Okay?
Okay, but we can leave this.
As you like. You may leave or stay or return, leave and then return as you like. I will be online. I will remain online. Good?
Okay, and our tasks are the table you showed us and the test. That's
Yeah,
it.
sure. Yeah.
Okay, thank you so much.
I will send instructions to you in email. I will simply write. Let me show you now. I'll show you the example. Maybe you'll get some questions immediately. Just one moment. I do this with other students as well, but in other subjects, you see. We have different subjects at our department. Let me show. Yeah, here it is. For example, sense, yeah? Not so long ago, I had some second practical class with some students. I wrote them. Let me enlarge it now, magnify. Useful link. So direct link, link to this document with my ask, fill the systematized information into the document, then pass the test. I supply some recordings if I have. Yeah, you may look my video of my lecture or anything. Direct links to each of topics of our today's class, etc. Right? So something like that I will send to you. Okay?
Okay, thank you.
Thank you. So see you if I could help today or at least other day.
Doctor. Doctor. Teacher. 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 Teacher.
You. Do you hear me now?
Yeah, you can hear me, teacher.
Yeah, of course.
I'm sorry, teacher. I have some more question, teacher.
Yes, please.
Now we should do just test text, yes?
Test. Before test, the document, the table in the document. Read the theoretical material, fill the table, and pass the test.
We just read and pass test, yes?
Yeah, minimally test.
Okay. Thank you, teacher.
Hello? Hello?